As I talked about before some of you got here, is we are recording now a lot of our lectures here because EMT refreshers, not a lot of people are putting them out there. So we're going to be putting this online, especially for areas that come out from distances, other parts of the state, and other areas that can't get into it. We're going to be putting this as an online aspect. So if you like the in-person, we do this about twice a year. This is our third time this year we're doing it. If you like the online, we're going to put an online aspect where you can watch stuff online, but there's a skill component, about 4 hours that can be done just about anywhere that someone's got a Washington State evaluator if you want to do it in Washington State. So we are going to be recording lectures today that I can be kind of putting on to give people other opportunities, especially in smaller communities and distance away that you don't have to drive several hours to get here. So talking about airway management is where we're going to start about. And of course this is doing this to me, so hold on just a second. We upgraded to a new PowerPoint, and as soon as it does this timing thing on us, and it starts advancing slides, so I'd take that off. Okay, so we're going to talk about, of course, the pathophysiology. Obviously we have to talk about the airway, and we'll go over the anatomy. You guys are familiar with the anatomy structure, correct? So basically when we have our oral pharynx, our nasopharynx for our passages in our airway, comes down into the throat. Throat, we have the vallecula, which is basically a little bit of soft tissue that will actually flap. It'll be sitting here like this, and it'll flap down. It'll cover over my trachea. The idea is to prevent any food, liquids, anything like that getting down into my trachea and down my lungs. Esophagus is behind it. Our trachea has a cartilage system that's around it. There are rings that there, and they hold that area so the trachea can't get compressed. The thyroid cartilage and the cricoid cartilage are the two main bones. When we talk about gentlemen having an Adam's apple, that's our thyroid cartilage. And then we have the cricoid cartilage below it. Right in between there is called the thyrocricoid membrane. This is an area that if we need to do an emergency trach, or in kids we do needle trachs or things like that, that's the area that we're cutting. So we really have to know those landmarks. Another thing is too, is if we find people that we can't really find that landmark, really obese neck, goiters, other aspects, they're going to be really hard to intubate. They're going to be really hard to manage those airways. So that's a quick thing. If you can see pretty easily the neck and the thyroid, that airway is going to be pretty easily to manage for you guys, even with eye gels or whatever. If you find someone that you can't see the landmarks really easy, that's going to be a difficult airway to manage. Just be prepared for that. So you may have to do a lot of maneuvers. You may have to jump into the headway. You can put an eye gel in there, a king airway, depending on what you guys use, and you may not be getting good lung exposure, and I've seen that happen before. So good idea if you're going to have an easy airway or not. So big things that we see with the airway is going to be areas that obstruct. Different things that can happen with this. Obviously when we're dealing with kids, foreign bodies, or older people as well who aren't chewing their food as good. Anyone who's choking, so we can see obstructions from there, from either food, toys. Kids are going to be probably the most common we'll come across with this. Liquids. Blood and vomit. We had a gentleman we were going on the other night who decided to shoot himself in the head and filled his airway up in blood. So when he's laying down on the ground and blood's filling basically up into his airway, how do we suction that? How would you suction that? This is going to be interactive, by the way, too. So I would use, so what we start off is like a Yonker tip. Probably a good way to do. That's the hard suction. So pop it in. Now what does the book tell us? So you've been out for a little bit. What does the book tell us, do you remember, as far as how many seconds can we suction?
5 to 10.
Talks about 5 to 10, up to 15 seconds. A lot of different answers in there. 10's kind of where they stick at. 5, we want to be short. 15, maybe long side. Here's my thing. That's for the book answer. So if you guys are taking tests again, think 10. Think 10's a good number, less than 10 seconds, somewhere in there. But in real life, if that area is covered up in blood up to his mouth, I'm suctioning constantly. Because what if I suction for 5, 10, 15 seconds, and then I pull it out because that's what the book told me, right? But I still got blood up here to the teeth. How good am I going to ventilate that patient? Not very good. So I always talk about, this is the part I always hate about education, is we teach to a test and we teach to real life. I'm going to teach you guys a lot of real life, but because I know some people are going to be taking tests, I'm going to make sure we hit some book answers as well. So when I'm suctioning from in here, I'm suctioning the entire time.
I may find that if I'm doing an intubation on someone, I've got a hard tip, yonker tip in there, and it suctions the entire time I'm intubating. So feel free when you're doing this and you have to suction someone's got vomit, you suction until it's gone or until it's down low. They may have it when you're laying down, and I'll show you in some of these airway mannequins. They may have it so it's the bottom of the throat and you can see it down low. That's perfect because it's below the level of the trachea and that person can breathe. But if it's filling up, keep suction until it's gone. So that'll be my key thing here. So how these obstructions can be, we talk about acute or chronic. Basically, acute, as we know, is fast, happens recently. Chronic, been over a long period of time. So our acute obstructions are going to be exactly what we talked about. Someone vomited, someone's filled up with blood, someone swallowed, a kid's had a toy, food, anything like that. Our chronic obstructions are going to be people who have asthma, they have chronic COPD, emphysema, things like that that can block the airway and going to be affecting the pipes. So this is the area too, and how we treat the person is going to be finding a history. For me, the most important aspect of being a medical provider, no matter what area you're in, is getting a good history. And if you guys do a good job of getting a good history on someone, you'll know exactly what you need to do. Very simple and do as far as treatments. So those are the kind of things that we're going to be looking for. We talked about this, and we talked about this. So the other aspect that this related that I didn't come into is edema from burns. So burns, really, this is technically more of an acute injury in my, put it under chronic or appearing over time where it goes, but basically you ever see someone who is involved in a burn, they come out of a fire, you see any blacking around their mouth. I ran on a gentleman, and God, you got to love these people who have to smoke. And if you smoke, I have no problem with that. Just don't smoke with oxygen in your mouth. So ran across another gentleman who decided to put his oxygen down here. He thought that would be a good idea. So its nasal cannula is sitting right here as he's smoking, and it shot right up, burned right through his, he's got a full beard, except for right here now. Nice burns up into his mouth, into his airway. So you do that over time, you're going to get some swelling from burns. Fortunately, he didn't have it up his nose. I've seen that too before where you see black through. That's not going to be swollen initially, but you got to be prepared for that person. That person's going to swell over about an hour, could be 10 minutes. So those are persons you got to watch for. If you see any burn, any charring around the mouth, any from that, be prepared that the airway is going to go away. So you got to be prepared. How am I going to treat this? How am I going to take care of this? And if that means any of you intubate, okay, so if you get someone from there and you're thinking it's pretty much a BLS transfer, but that person's got recent burns to their mouth, maybe you're thinking, hey, I need someone here who can take care of this airway, so I better call a bird or I better call a medic or someone there that can take care of that airway. So be prepared from those type of things. These are the other areas here. So some of the big obstructions that you're coming across with this, asthma is probably going to be the biggest one I think you guys will come through. Asthma attacks causes that bronchoconstriction really over an acute period of time, and it can swell and can go over. We talk about COPDers, emphysema. They're used to it. We see them in a chronic area. They may have some difficulty breathing coming on, but it comes over a period of time. You see it, they're kind of used to it. You will be doing that. But asthma is going to be one of the big ones here. So today I want to kind of hit on that phase when I get to the asthma portion and talk a little bit about treatment and see what you guys are doing and see if I can change your minds on a couple added things. So, patient assessment, when we're going on an airway, so very common, and I get this all the time, you get from dispatch, difficulty breathing. So what is it? I don't know, it could be a ton of things, right? So you got to be running through your mind all these aspects. What could this be? Because it can be a lot of different things. So the important things I want to do is I want to say, is the airway open? Is the person breathing? What's going on with that? Is the airway going to stay open? So what's an indication where the airway is not going to stay open that I just talked about? Burns. That's the area where the airway is open, but if it's got swelling and he got heat into the mouth, that tissue is going to swell and that airway may not stay open. And then what are we going to do with this? So is the airway open? Are they breathing adequately, and do they need oxygen? Those are going to be the key things. So is the airway open? There's multiple times where I see a patient laying down flat and they're not breathing. Well, it's because their airway open. We got to go talk about anatomy again. So let's say I've got a 1-year-old. And they're laying flat down. Is their airway open? Hard to say. May not be because, come on in. Well, let's find out. Where are you headed to? Who's putting it on? Okay. This is the EMT refresher. Did they tell you here, or what was the address? Okay. No problem. So there's a couple different things. So we sometimes do CPR training at the fire training center, which is just down the way. Did you park back here? So if you go down a little bit further past the field house, which is the big building, then you see the burn tower. To the left of that, that might be where it's at. No problem. You're doing fine. Otherwise, the other place, sometimes they have it at the fire station. Or the other thing is there's an office right here. Just go up here, take the next door to the right, go in and talk to Gary, see if he can help you out. You're welcome. So we got to open that airway. So if I'm dealing with a 6-month-old and they're laying flat, their airway's not open. Their head's big, it's controlled down. Kids, I may have to put padding under their shoulders. Adults, I may have to reposition their head. So we've got to check for those type of things and find out if they're breathing adequately. So what's the breathing rate for a 6-month-old? Do you guys know off your head? And it's okay if you don't. What's that? Could it be actually even 35 to 50? It's going to be a fast rate. So if they're breathing at 12, we're like, that's normal for an adult, right? Might not be normal for a kid. So it's finding out where their breathing rate. That might actually be slow. And kids are really respiratory driven. So if they're breathing too slow, it means their heart rate's going to stop. They're going to have problems on you. So you got to kind of know where they're going on and see, are they breathing adequately? If I'm an adult breathing at 35 a minute, am I breathing adequately? No, I'm breathing too fast, right? I'm not getting in and out. I'm moving air in my dead space. I'm not actually moving air in my lungs in a lot of cases, so I'm not getting good oxygen exchange. Breathing too slow. So these are all things you guys have to be able to assess is, are they breathing in enough? Are they getting good oxygen exchange? Because if they're not, that's our whole purpose. We're not going to be doing well until we get that. So we got to figure out what we need to do. And do they need oxygen? Does every patient need oxygen? Doesn't hurt them to an extent. For if you're alive and awake, doesn't hurt them. So I'm going to tell you about HA. If you go to HA, and they're going to talk about classes about having oxygenation, and basically we want to maintain them. If they're 94% or above, don't give them oxygen. I'm okay with giving them oxygen. The problem they come in with is with a dead patient or someone who's just coming out of recovery, we get a resuscitation. If we give too much oxygen above 100%, because what's the SAT level go up to? 99, 100%. So if I'm giving too much oxygen, does it tell me 110, 120? It doesn't. So what does oxygen do to metal? If you're going through and you do oxidizing injuries, it actually rusts it in that. So too much oxygen in the blood, if I have 110% in my blood, it can actually cause oxidizing injuries, cause free radicals to break down, and we get actually worse results. So you're going to hear this in future classes and stuff about over 94%, don't give them oxygen. My philosophy is, give them oxygen. Just, am I going to give it through a non-rebreather, or am I giving it through a nasal cannula?
Yeah, that's it.
Yep. It's the way of delivering. Yeah. And if they hit 100%, maybe turn it off. See how they're doing. So not every patient needs it, but in most cases it's not going to hurt them. But I will let you know, anything we give, oxygen is a drug. It's all based on the levels. So every drug is also a poison. It just depends on that therapeutic dose. If I give you too much of any medication, I can kill you. I can actually give you Narcan right now. And most people say, Narcan doesn't hurt you. Helps you, right? If I give you Narcan and I give you a higher dose, I can actually put you into a seizure. So I'm getting off topic on my other things there. But so I'm just kind of going to the point that every medication technically is a poison. So it's all those type of things we need to take a look at. So that's basically our foundation we're going to be building on. Those are the steps. You find out those things, that's going to tell you what you need to do. There's more questions you need to ask, but basically if you get those few steps down, you're going to know exactly what you need to do. Do I need to BVM this person, or are they adequately breathing on their own? Do we BVM people who are alive and awake looking at us? Absolutely we do. They're breathing at 35, 36, I'm going to BVM because I'm going to try and slow them down. If they're alive and awake but basically altered and they're breathing at 4, I'm going to BVM them. So we are going to be using those. Our SpO2 is going to be a good monitor, but the other thing I want you guys getting used to is capnography if you guys have that ability. Now, is capnography in your scope of practice? I don't know. Depends on where you're at. If your state, if your county or facility does it, I don't know. If you don't have a monitor that reads it, probably not. But you guys should get used to doing it, especially if you do work in an area that has a monitor. I know you work at Deer Park. You've always got a monitor on your rig, right? So you can always throw it on. It doesn't hurt to do that, and those will help you kind of decide, because capnography is a better indication than SpO2. SpO2 is actually a look in the past. Gives us a future of what was their rate being, but it takes a while for that level to catch up when you decrease, where capnography is instant. So I'm going to go over that stuff with you today too. Okay. Position-wise, I'm going to skip. Inability to speak. Here's the big aspect. If I'm talking to you guys like this, am I having acute difficulty right now breathing? Okay. And it sounds, and for obviously because you've already heard me, I am. So here's the question to ask. If you can find someone around, is this the way he normally acts? Is this the way they normally talk? Is this new presentation? Is this acute, or has this been going on for a long period of time? I'm actually going to tell you, there's some people actually that's their maintain, and that's where the level they're at. They're going there, and there's other reasons on there. So you got to ask them, how is that ability? But usually if I'm talking like that, that's an indication this person's having problems. I need to get oxygenation and get them on set. But always be asking, if you can, bystanders, not bystanders, family members, anything like that, is that normal for them? How long has this been going on, those progression? Because if I've been talking like that for about the last 15 minutes, 20 minutes, am I in an acute area where you guys need to worry about me dropping my respiratory? Probably not. I can maintain. I'm getting close, but I'm probably not going to collapse on you instantly in most cases. Again, I got to generalize, because that person could collapse on you, right? But if it's only been happening for 15, 20 minutes. Now, if I tell you that's been happening since 9 a.m. and right now it's 11 at night, that person's reserves are going to go down on you quick. So it puts a little extra area into going, I better start maintaining, I better start getting my airway kit out, I better start being ready for this person to collapse on me. And then stridor. What is stridor? Exactly. So it's basically an obstruction in the upper airway. When the air's trying to move, it makes a high-pitched sound. So if you hear that, stridor is an inspiratory sound. You're trying to take air in. So anything air in, it's an upper airway. It's usually an area of obstruction. So I'll give you this pointer. If you're listening to lung sounds, and I would say anytime someone has difficulty breathing, get a set of ears out. Listen to their lungs. And I don't care if you can tell me what crackles or rowels or ronchi is. If you tell me it sounds junky, it doesn't sound normal, perfect. Does it sound wet or dry? That's all we need to know, right? So if you listen to, you hear sounds with inspiration. So when they're taking a deep breath in and you hear a sound, that's upper airway. So now you can think obstruction in those. If you hear a sound on expiration when they're breathing out, that's lower airway. So that's actually in the lung tissue. So now we're talking more disease process. So it can really tell you where they're at. If all the sounds are upper airway, thinking that's a tightening of the trachea. So that's your asthma. That's your croup. That's your obstructions. You hear lower so you don't hear sound necessarily on inspiration, but you hear wheezing. You hear wet. You hear ronchi. You hear nothing coming out. That's lung disease. So it's two different processes, so you guys can be thinking about what you need to do. The lower airway, what are you guys going to do for it? Nothing, unless you're an advanced EMT and can do a nebulizer, right? That person needs medication, so you may not be able to do anything for it. Upper airway, what can you do? Well, obstructions, that we'll talk about asthma. You guys can do a lot more. But again, it lets you know, again, if you're listening to that patient and you hear lower area, you know you want to get that patient out of your hands as quickly as possible into someone else's, right? So those are different ways it can go. What does snoring mean? Absolutely. Usually it's just the tongue's falling back. We got to lift it up. Simple ways. Jaw thrust or an OPA, if they'll take it. So if you guys put an OPA in, how do you guys determine whether their gag reflex is intact or not? So that's one way to do it. Now I'm going to give you another trick, because that's not the way I like to do it. Because if I put it down in their mouth and they decide to puke on me, if they start gagging, I'm okay, right? I just pop it out. But they decide to puke on me, I'm like, damn it, just ruined my day. I got puked on. I don't like getting puked on. So, anesthesiology trick. If their eyes are closed and you rub their eyelashes and there's no flinching, there's no twitching, that's basically after we give propofol in the OR and that, check the eyelids. If there's no response on it, they have no gag reflex. So if someone's out, you can do a quick area. Do they move? Do they twitch? Do they do anything when you're touching their eyelids? If they don't do it, then you know you're safe. So it's a quick little way besides sticking something down their throat to see if they're going to throw up on you. But we know how to fix it. And gurgling sensation, you hear that at all, this is going to be key for taking the National Registry test, because if you hear gurgling sounds when you approach the patient, that's airway. Airway is before breathing, so what's the first thing we do? Suction. So that's how we fix it. You guys all heard stridor before? High-pitched wheezing sound. If you haven't, that video won't play for some reason, so I'm just skipping on there, but I can show you what that's like if you're interested in it. So basically, we've just got to be checking that airway at all times. If we have any area on there, we've got to figure out why is the issue, what do we need to do, and we got to keep monitoring this. This is something that we're doing. We're checking like vitals. We're trending it. We're watching how the airway are. Anytime I do any treatment, maneuver, procedure, anything, are they responding to it? And I got to keep coming back to it. I got to keep monitoring, because ABCs are obviously going to be our most important signs. And anytime we're dealing with the signs of it, what basically are we doing? Well, we're kind of checking for all these things. Are they moving air? Are they making sounds? Are there any indications that this patient could change on me? When we go from a normal speaking voice to a hoarse and raspy voice, and I start getting in, my voice is changing over time, that means there's swelling going on. That should be a key red flag to say, hey, I better get this in someone else's hands, because if that swells up too much, the only way I'm going to get that airway is through here. And if you guys can't do that airway that way, you need to get it into someone else's hands. So these are going to be determinations of what you're going to do. And then watching chest rise. Here's my biggest thing. I'm also going to stay on lung sounds when you're doing it. If you're listening to lung sounds and you don't hear something that's not clear, just make sure you're saying, I don't hear something over there. So what does that mean? It can mean a couple of different things. Sometimes with pneumonia, there's no lung sounds. I had one patient where the EMT was telling me, I can't hear anything on the right lower side. Can't hear any sounds on there. I'm like, nothing at all? I go and listen onto there, and again, I have nothing. What's the one person I didn't ask? The patient. So I listened to the patient, and I said, hey, I'm not hearing any lung sounds down in here. Of course, we were just putting the tube up throat, and I wasn't exposing, so it goes to a couple areas of why we expose our patients in that, but I just put it up here and listen. Like, so you have any problems with your lungs? Because I'm not hearing any lung sounds. Oh, yeah, I had that right lower lobe removed. Well, that's why I didn't have lung sounds on there. So different reasons that you can be and find out there. So just make sure you're checking, you're evaluating. So when you are listening to lung sounds, feel free to lift the shirt up. Again, if we're dealing with females, we don't want to expose everything from that. We want to keep area, but sometimes we got to check things. Scars, things like that tell us a lot about the conditions we're doing. And then other signs of bad breathing. Abdominal breathing, we're going to see a lot in our kids. Kids are going to be our most difficult aspect in watching them and figuring things out because their respiratory drive changes so much. But that's another reason why we got to get the shirt off. We want to see, are they using accessory muscles? How are they breathing? Do they breathe? Are they looking they're adequate? Or are we seeing movements where the muscles in between the ribs are going in and sucking in? Are we seeing other aspects that can be going down? That's those retractions. And then we got to make sure we're listening to see could anything else be going on as far as are they developing a pneumothorax? Are they developing a tension pneumothorax? Could they have what's called a PE, a pulmonary embolus? All these things got to be coming into play when we listen to it. That was another video that does not open here. So let's talk about opening the airway. So we're going to go through a couple patients here. So you get this patient, you get an auto versus ped. You arrive on scene, you see the patient like this. What are you going to do?
Mobilize C-spine.
Fantastic. So this is the area where C-spine is technically before airway, right? So we're going to mobilize the C-spine. Then what are we going to do? Fantastic. I would. Now, if he was in a position that you could manage the airway, can you manage the airway from there? No, I can't. So, I mean, I really could if I tried, but why would I want to try in that situation? So get him rolled over. Now, how are we going to manage his airway because he starts getting snoring respirations or he's not really breathing very well? Fantastic. What else? And I'm not saying right or wrong, I'm just thinking out loud. What are the other possibilities you can do with him?
Snoring.
Mm-hmm. Yep. OPA. Be thinking those areas. Would you do an NPA on him? Maybe he's got a gag reflex. Why wouldn't you do an NPA on him? What would be some of the reasons you might not do an NPA on him? Yeah. Any aspect of head injury. So again, if he's got a gag reflex intact, I can just hold the jaw thrust, but that's also going to be, that's a pain in the butt, holding a long time, right? So I'm like, I'll put an NPA in. That'll be easier to get right in the area. But remember that skull, it's a fixed cranium. So if I get a crack to the back of his head, now obviously he looks like he fell on his stomach, but let's say he got hit in the back of the head and he's got a crack to the back of the head. What happens to the front? Well, the thing acts as a shock wave. So that area is thick on the back. It is hard to break the skull in the back. So if I broke the back, it shock waves up to the front. Well, right back here is called the ethmoid and the sphenoid bone. So if I pop it up here to Z, this little bat-winged area right here that's underneath the orbits, it's called the sphenoid bone, and the ethmoid bone is right in from there. Those things are eggshell thin. So they're easy to break. So that shock wave from hitting the back could basically transmit right there and break those areas. Well, where do they happen to be? Fortunately, right in the nasopharynx. So if you put an NPA in, you could push brain fragments, or excuse me, bone fragments into the brain, or you could potentially push that NPA up there. So just because you can do something, always be thinking of that. If you're worried about head injury, facial injury, anything, take NPA off the table. How about this patient? What do we think when we see this patient? What's your first thought, Dawson? You're thinking the zone, right? So we're thinking, he's intoxicated, could be overdosed, anything like that. But we got to figure out what's been going on. This could also be a diabetic patient, could be anything. But how are we going to manage the airway on here? What's the first thing we're going to do when we approach him?
See what his responses are.
Okay. Okay. So I'm going to challenge you on one other thing, because you're right, that's what we're going to do. But the last patient, we went C-spine immediately, right? Did we go C-spine immediately to him?
You can reposition and see if there's any signs of breathing compromise. You can
Right.
realign his airway there.
But it's funny because we go with the perspective. We think about car, we think about trauma, we don't think about C-spine. It didn't come up as everyone's first area, right? On this one, it should. Because what could potentially have he done? He could have been sitting down on the curb and just laid back. He could have been standing and fell. Standing from a height? Say he's 5'7", 5'8". That's a good crack to the back of the skull. Could have happened to it. Yeah, Kyle.
Were you bothered to move him to put him in like a safe location or get him all the way on the curb or all the way on the street so he's not elevated like that?
You can change it. The nice thing is the only part that's not elevated, he's got a good resting spot for the femur. He's hanging off. In my mind, that could be okay, especially if this is sidewalk and if I use vehicle apparatus to block the road. But good idea. If there's an area of safety, absolutely. Scene safety actually is even before C-spine, right? So if he's not in an area that you can block and control the scene, absolutely move him. Would I try and manage him like this at first? Probably at first for the initial, but yeah, I'd probably consider moving him later. But if he was out here, I'd be blocking those scenes and I'd be trying to say, let's get him off the road as soon as possible in a safe way. So good thoughts. So on this patient, again, we don't know exactly where he comes to. So don't forget, just because he got a man down in the zone, that he couldn't have fallen or had some type of trauma associated with it. So we got to be thinking about that aspect as well. How about this patient? How are we going to manage his airway?
Conscious?
He's conscious.
He's lost consciousness.
He's LOC, so he's altered. But he's still, his level of consciousness is going, but he's still alert. You can see he's still looking at you, but he's altered and he starts to snore. Yeah, position his airway. Do simple airway maneuvers from there. We put an MPA in him, right? No, because we got all this facial trauma, right? So there's a good chance he's got a crack across one of those bones. So he starts to snore, we can't put those in. Can we put an OPA in him? Probably not if he's got any aspect of having a gag reflex intact. So we got to manage it in another way. You guys can't take his airway, nor would I want to at this point, so it's positional. Lifting him up, getting him in position area so he can breathe. What about this gentleman? This is a guy from the zone. So you start looking over here, he probably OD'd on something. But what's your first steps on this? Am I probably worried about C-spine on him? Again, there's potential. He could have fallen and hit his head into this brick wall. So I'm always going to err on the side of C-spine precaution. I might find out later that, nah, he was leaning against it and he just slid down. But I'll always err on the side of C-spine precaution from this. How are you going to manage his airway? He's probably completely unresponsive. He may not even be breathing here soon. What's your first thought of managing his airway? Okay. As with anything, get him into space you can work with him. What's next? What are you going to do for him?
Just have to get him away from the wall, just repositioning in a natural alignment. See how that does that.
Okay, so you pull him away and he's still not breathing. He's got a pulse, very weak. He's got a good carotid, very weak, but he's just not breathing. So based on the situation, what do you think's going on? Possible OD, obstructed traumatic. So be thinking, because if he did something in here, what are my two top priorities for him? Well, one, he's not breathing, so I better get a BVM ready. Two, I'm going to start thinking Narcan on him. Now, Narcan's a medication, right? But you guys can anyone not give Narcan in your protocols? Okay. So be thinking about that way, because technically, that's going to restore his airway back in place too. Not one of the things we think about airway procedures, but it's something in this case that you may be doing. And does everyone have a MAD device? I should say this. Does anyone not have a MAD device? I know you don't. Yeah.
What is that?
Perfect. We're going to talk about it in skills then. So that's a fantastic thing. So I'm going to go over a lot of different things on here. If your department does not have a MAD device, then we're going to tell you about them, show you on there today in the skills portion. And it's a fantastic tool. Not often are drugs part of our toolkit, but it should be. Should be something to be considered, because that's managing his airway. You take care of the reason that depressed his airway, you fix that problem, his airway comes right back. And with these patient OD, as soon as you pop them some Narcan, how many full arrests have you been to, Dawson, that you give Narcan and they all of a sudden they're breathing, they're wide awake again? So,
if we go back to that picture, it looked like cocaine, which is a narcotic, and you push Narcan, it's not going to do anything. Narcan's
correct. So if it was cocaine, it wasn't going to be that aspect. Correct. But if you took opioids or something area in there, but again, if it's Narcan, can it respond against cocaine? In some cases, they do have some crossover. Some cases, they don't. But it's not going to hurt him in this case because he's unconscious. Now, giving Narcan on a live patient can actually throw him into seizure. So I never give Narcan. Even if someone took an opioid and they look like they're going to go out on you, I don't give them Narcan until they've gone out on me. Great point, though. Biggest thing here, like I said, we're just making sure that any time that we have this, we're being proactive. We know exactly what's going to go on. We've got a good assessment. Our big thing is you guys should be getting good at this. You'll get better once you get out in the field practicing a little bit more. But one of the things you guys should be really good at is seeing every patient and going sick, not sick. It's our system one response. Is this person like, I got time to play, or does this person need help now? And be judging that the whole time to go, something's going to be happening here. I better be prepared for this. I better be prepared for something's going to go down, and I got to take reaction for that. We talked about positioning and that. Again, if there's no C-spine precautions, sometimes a simple airway procedure like this, or on kids, padding, positioning the head, getting the head and chest relationship. The other aspect that this comes into play that I've seen before, football players. What's the tendency on football players who are wearing a helmet who are having an airway issue? Anyone done a standby? The tendency of what we do. So you see, you go on the field, you're on a standby, you go on the field, you got a football player who's laying down and he's got his helmet on. Do you pop the helmet off? Okay. You can get the face mask off so you can work on that area. So you got to be thinking on those cases, they've got a set of pads, usually in most cases, and that helmet leaves them to the area where they're at the same area. Some people, and I've been on there, the tendency was to take the helmet off, and if they do that and their pads come up, what did I just do to the airway? I hyperextended. I can block it the other way. I'm not in sniffing position. I just blocked it the other way because now I got this pads up here. So a lot of times a face mask I'll remove so I can still manage the airway. Now if I need to move that helmet to manage that airway, I better remove those pads as well, or have some kind of padding underneath that head to keep it balanced, because it's not just this way that causes airway obstruction. This way does as well. Don't really need to go over this. I'm assuming you guys all know how to do this. Grab the jaw, easy maneuver, lift up. The only hard part is when they had a facial injury right across there and that jaw's broken, right? So we're just going back again where that attachment is, and we're trying to be careful in moving that spot. And then, like I talked to you before, as far as doing the management, our big thing is we want to get rid of the secretions, make sure the airway's open, and go from there. I'm going to pop through some of these things here because we already talked about them. So when we're dealing with these two, again, important aspect, and the only reason I'm bringing this up too is because these do come up on test questions at some point in time. You guys all know how to size these, right? You all know how to put them in? So basically, on kids, the only reason we don't put them upside down is because they haven't developed that hard palate yet. So kids, we can actually put them in, and I've got some in the back, just straight in like that. We don't want to push the tongue back. We want to get it over the tongue. And actually in kids, their tongue is huge inside their mouth, bigger than in adults, covers a lot of space. So sometimes we may have to grab that tongue to pull it out of the way or slide it around the side.
You want to do sizing real quick? It's corner of the mouth to earlobe, or?
Correct, to either earlobe or corner of the jaw. So yeah, from the mouth, thank you. Yep, so sizing up there, this part of the hub should be right up here at the lip and then back here. Nose, if we're doing the NPA, same type of thing, from the nair back here to the corner of the jaw, earlobe, any function from that. Vestibular process, whatever the landmark is, any landmark in this general area works. Thank you. So as far as sizing that, if I'm doing this pediatric patient, I put it in just like this. So if this was my mouth, it's coming in just like that, right? Straight in. I can go over the tongue. I can turn these sideways in adults and get in around there, or I can turn it to where it goes the hard palate all the way back and then flip it in the back. Can I take this and put it in my mouth just like this on an adult? Absolutely, I can. As long as I get it behind the tongue and I'm not pushing the tongue back as a further obstruction. So getting it in, again, I'm not too worried about that aspect, but it's usually easier to go sideways or upside down on adults and flip it back in, pull that tongue up. There's actually a new one coming out. Respiratory therapist who was on MedStar actually invented it. It's pretty slick. This is on a slide. There's a little area here too. So what you'll do is you'll slide that base across the tongue. As soon as you get behind the tongue, you pull on it. This part slides forward so it catches the back of the tongue and pulls it forward. You pull it forward enough. I actually put it in myself with my gag reflex intact because it pulls the tongue back. And this base here comes far enough forward, it doesn't affect my uvula and doesn't cause a gag reflex. It's actually pretty slick. I'll have Sean show it to you today. We have one here. We can clean it. Well, actually, for Dawson, I'll just leave it dirty. But we can clean it, and you guys can actually put it in yourselves. But yeah, it's got a little pull slide onto it. So as soon as you get back and you start to gag, you catch your tongue and you pull it forward. You have it sitting in your mouth, and it doesn't cause a gag reflex. It's actually really slick. It's a great idea. I don't know what cost-wise is to get them in. Here's that sizing. So again, we talk about the angle of the jaw. But technically, because of the way tests are written, earlobe, angle of jaw, mastoid process, anything in this general area is going to be there for sizing. You can do it forward. You can do it backwards. You can do what's called the scissor aspect of opening. You can grab your thumb and reach in from here and grab the tongue to pull up. Lots of different things. I always hate putting my fingers in anyone's mouth because you just never know if they're going to get C's or anything like that, and it grabs down to your finger. Could be an issue. And we kind of talked about this, about inserting and positions. And this is the area here that I was talking about. So once we get it back behind the tongue, we're holding it up. Now I'm going to show you, we have a couple of different types of OPA. Some, this is just a ridge that comes down here. Some of these, there's actually a lumen in the middle of the OPA to allow that oxygen to come down. Now on these slide ones, this will actually, right here, when I get in this area here, this is what's going to cause the gag reflex. So if I'm able to slide this forward to where this base is now right in this area, or basically, because I have it, if I can adjust that base to where it's now here, I'm beyond the gag reflex. So I can actually use an OPA on a not conscious patient, but a patient with a gag reflex intact. And then can BVM and work right around it. So the nasal pharyngeal, here's the sizing on that. Again, kind of the same thing. Make sure you lube these up. They talk about one side being bigger than the other side as far as fitting in there. You can put it in either side from there. I'm not a big fan of these, but I don't need to use them. I have the ability to do other things. They've got a gag reflex intact and they're unconscious. I can take their airway away. You guys may not be able to. So be thinking about all your options. So again, I'm not good at this tool and I don't like this tool, but that's my personal preference. For you guys, it may be a great tool. You guys be good at it. And again, you guys should be good at everything that's in your box. We're going to show you different equipment today. It may not be the equipment you guys carry. Be good at the equipment you carry. Know what's in your equipment. Know what's in there. And we're going to talk about different ways of using them, and so you're sufficient with that. So lubing these up so that they slide in. Again, anytime you're coming in and you are placing these, if you're going up, you hit any type of resistance, pull it out. Don't push it, don't force it, don't slide it. Try the other side unless you're suspected facial trauma, skull trauma, anything like that. You guys can put these in today. I'll spit on one for you if you want to put it. I got to give you a bad time all day long. So yeah, we have different people come put this in. I'm actually going to show you another video here in a second. And then basically suctioning devices. Again, we kind of talked about the suctioning. There's different devices out there, so many different type of equipment. You may have something that's mounted like this inside of an ambulance. And with this, the most common device you guys are going to be using is going to be this rigid tip, or basically a yonker tip. So basically it looks something like this. It's got a hole on it that you make sure you put your finger across it so you're suctioning. Pop it in, get down into this oropharynx. Again, if I see fluid right here on this level, should do it right here. Okay, so if I see fluid down here, I'm not worried about that. To that level, if I see fluid down there, I'm okay. Realistically, because the trachea is up in this area. The vallecula, right, what I think is kind of funny is sitting right there. It actually flaps a little bit different than this. But that's an area. Now, if I see fluid up to this level, I'm going to suction that until it's gone, until it's down to this area here. And if I suction and it comes down and I pull the suction out and it starts filling back up again, what am I going to do? I'm going to leave that suction in there. And I'm just going to suction constantly. Because what's the use of a patient if their airway's blocked, right? Got to keep doing that. So there's different ways that you can suction. These hard tubes are in there, and the other ones are the French cath or the flexible tubes. That's once you have an I-gel in place. You have a King airway in place. You have an ET tube in place. You may need to suction those because we start getting blood into those areas. So that's a soft tube that you can come in. Basically, how we place those, you guys are familiar with the carina? You ever heard of that term? Okay.